right, I'm going to continue on with part 2. We finished just talking a little bit about intraventricular and intrathecal chemotherapy, and this is just a picture that kind of lets you see how they put intraventricular chemotherapy through intraventricular catheter injection into that ventricle in the brain. And then also for intrathecal chemotherapy, you can see how they're putting that into the spine, lower down there, directly into that space. And that type of chemotherapy can also be absorbed up through the spinal fluid to the brain. So treating cancers of the brain is always a little bit different than some of the others because of that blood-brain barrier. And so putting chemo in the bloodstream doesn't always get fully to the brain. All right, we're going to continue on here. As we've talked before, chemotherapy has effects on normal tissue along with the cancer cells. It can't distinguish between normal and cancer, so its job is to kill cells and destroy cells, and this leads to a lot of fatigue in the patient, anorexia, taste alterations. They may not even sense how something tastes for many months following chemotherapy, which adds to the problem with lack of initially sometimes it's a lack of interest in eating because of fatigue or severe nausea because of the treatments. And as we talked about with the HIV patients, sometimes they do get thrush in their mouth, sores in their mouth from the chemotherapy also. And then on top of that, some of the drugs actually mess up the taste buds in the mouth as well as when it's killing other cells. And so they may not have any sense of taste and just not have an appetite at all. So drugs for chemotherapy are given in combination, as we talked about, very precise based on the staging and the type of cancer and the type of cells. Dosages are carefully calculated based on body surface area. So you really need to make sure that you're always getting an accurate height and weight on your patient on admission. Selecting drugs with different modes of action sometimes may minimize the occurrence and the severity of side effects and things. So giving it more than one different way may help with that problem. Now let's talk a little bit about radiation. This is local treatment modality. So you're usually, finding a specific cancer tumor or area that there's cancer growth in, and it is one of the oldest non-surgical methods of cancer treatment, and 50% of all cancer patients will receive radiation. So a fairly large component of patients will opt, or their treatment plan will include radiation. Usually normal tissues are able to recover from radiation therapy, but it takes a while. And cancer cells are more likely to be permanently damaged. So when you think about chemotherapy, it's killing off good and bad cells. Radiation, may damage some for a time period, but they're able to kind of recover and regenerate as long as they're not cancerous. The dose, again, depends on the tumor size, the type of cancer, and then the treatment setting. Some patients may live long distances that makes it impossible for them to go to radiation 5 days a week. So that is a consideration with radiation's appropriateness, is proximity that you have to that treatment setting and whether they have that capability. Radiation can be delivered externally, which we've seen in some pictures, or internally, and I'm going to show you some examples of that. It is used in primary or definitive therapy, and by primary therapy, that means that is their main source of therapy for a cancer. And sometimes it can be used, alone. Also, it may be given as an adjuvant or neoadjuvant therapy, meaning that it's kind of given to assist with either the chemotherapy or surgical interventions. It can be given prophylactically also to certain areas that are prone to have regrowth of cancer. It can also be done just in a specific area to kind of control the disease or palliate the disease, meaning that it's not going to eradicate the tumor, but it may shrink the tumor, periodically keep it to a smaller size for a longer period of time, or it may shrink the area where it's pressing on something and make it easier for the patient to tolerate the pain of the tumor. External radiation is called teletherapy. It's the most common type. It's where the patient's exposed to radiation from a megavolt machine, and here are 3 different types. You won't need to know that for testing, but just kind of recognize that there are varying types of machines that can deliver this radiation. This is a linear accelerator. You can kind of see where the patient's face is covered, and they're set on the treatment table with very precise markings usually on their body. And here is the patient that's getting this radiation for head and neck cancer. Here is the Gamma knife. It looks just a little different in that you're being usually, very precision, from multiple different directions. Are you receiving radiation, as you see in the blue side of the screen, to really target a tumor very, very precisely? And this is a very expensive type of radiation that is not available just everywhere. Collaborative care for radiation when it is internal therapy. And you may not be aware of this, but some patients actually get implanted radioactive seeds that are left in the body close to the tumor to try to kill off the tumor. They also, and this allows just for minimal exposure to healthy tissue, and it kind of gets right at the source of the tumor. So one example of that is using these seeds that they place in the prostate that helps with just localized radiation treatment. And then the last picture at the bottom, you can see where these radioactive rods are being placed into the cervix for cervical cancer, and these would stay in for a period of time while the patient lays still and you're providing care for the patient, and then after so many hours then they're removed. Just remember that internal radiation is brachytherapy and external radiation is called teletherapy. More things about internal. You can kind of see the patient following these procedures is usually emitting radioactivity. So you have to limit the amount of time that you're spending with these patients that are being treated. So make sure you're organizing care. In some cases, there may be shields that are put into a patient's room or a treatment area, and you may have to wear a film badge that is periodically read in radiology to monitor your actual exposure. It kind of goes without saying that women who are potentially trying to get pregnant or are pregnant really should not be assigned to these patients during this time. Common side effects that you see with chemotherapy and radiation. We've talked already about how the bone marrow is suppressed, and in that situation the bone marrow doesn't make the blood cells as fast as they're being destroyed, so you get a net result of very low red blood cell, white blood cell, platelet counts, and if it's all 3 of those together, that is considered pancytopenia. Patients will be very fatigued. They may have serious GI upsets or disturbances, lots of nausea and vomiting with chemotherapy. They may have skin issues, mucosal reactions in the mouth to chemotherapy. They may have skin issues related to radiation directly to the skin, very reddened areas from the cancer radiation area. Sometimes you see pulmonary effects, and by this I mean a lot of these chemotherapies are given very rapid, large volumes, amount of fluids, and so as we've seen with lots of types of patients that are older, they may not tolerate, their kidneys, their heart, their lungs may not tolerate large volumes of IV fluids, and so you get this situation where suddenly they're having a lot of rows or rattles when you're listening to their lungs. That's a sign that they're not tolerating the large volumes of fluid given in chemotherapy. And, they may have to have some other types of treatments, like with Lasix or furosemide or other drugs to kind of pull off some of that excess fluid that's collected in the lungs. Obviously, you've heard, I'm sure, that radiation and chemotherapy may affect someone's ability to produce eggs. Lots of women that go through treatment will go through early menopause. Many men that are getting these treatments may no longer be able to have active sperm. And so a lot of times patients will be taught about this if they're younger so that they can store their eggs or, put back sperm samples for later on if they intend to try to have children at a later time. We've already talked a good bit about bone marrow suppression. It is the most common side effect. These treatment-induced reductions in red blood cells and white blood cells can also lead to infection, because you can imagine you become very neutropenic. Sometimes you may have some hemorrhage from this kind of destruction, and patients, as a general rule, will have overwhelming fatigue. And by that, you can expect 70 to 100% of the patients will experience that with these treatments. So it's very important in an ongoing way to encourage them to really rest before they have a big activity, get help with activities of daily living, structure their time, do little bits at a time, and rest periods in between are standard care for this type of fatigue. Make sure that they're maintaining their nutritional and hydration status with whatever high protein, high calorie foods like we've talked about for the other diseases. These folks need this too, along with good hydration. And they may continue to have this fatigue sometime after treatment. So every follow-up appointment, you're asking about this again and again in the clinic setting. GI effects, often we're given antiemetics. We're going to assess, their CBC along with their BMP, because you're looking for signs of alkalosis, dehydration, what is their I&O balance. Often you want them to take high calorie, high protein food, but something that's low fiber that won't irritate the GI tract. These are some of the GI effects that you can expect. Sometimes they need anti-diarrhea. Sometimes they get the opposite problem. They have enough dehydration that their bowels don't move, but a lot of times it's diarrhea, and they need meds that kind of slow down that process. You want to monitor their weight very carefully, at least twice a week, and again, focus on small, frequent, high protein, high calorie meals, and encourage them to have nutritional supplements as well. Make sure that you also teach patients to examine their oral cavity. Some hospitals actually have a scale that they use to evaluate that each shift. And all dental work should be performed before you initiate these treatments so that they don't have the opportunity to develop bleeding or infections worse in their mouth. Skin reactions, these are some other things. Making sure they keep their skin well lubricated, and stay away from irritating substances, and keep very dry. And again, your goal is to prevent infection and facilitate wound healing. Keep them warm.